Okay. A couple of little updates kind of as follow-up. Dr. Dahm, the immunologist from Holland, has told me now that the children that are getting either IVIG or the prophylactic antibiotics are doing much, much better in terms of reducing the number of infections. So I think that research, what you presented, has really been very important to help literally save lives. And so if your child has not had a complete immune workup, I very, very strongly recommend that. And in fact, what I really hope to do very soon is to come up with another protocol, just like the bleeding protocol for the immune system, okay? One other interesting follow-up, you talked about the ETS1 gene as maybe one of the causes. It is interesting that in mice, if you look at their immune system, if you get rid of the ETS1 gene, they have exactly the same kinds of problems in making antibodies. So we've actually recently identified a human patient that has some of the same problems with Jacobsen syndrome, a very severe heart defect, some intellectual disability, ptosis of the eye, and he's had some recurrent skin infections, but no major immune infection, severe infections. He actually has a mutation in the ETS1 gene. I've been working now for about the last year, but finally, in the next 1 or 2 months, we're going to be able to test his immune system to see if, because of that gene mutation just in that ETS1 gene, if that might really be the cause of some of these problems. Okay, moving along to another subject. I can promise you in this talk I will not show you any pictures of genes, so this is going to be all about a clinical problem. So what I'm going to do is give you some history of what came to our attention about some children with Jacobsen syndrome that have had very catastrophic bleeding in their brain. I'm going to tell you about the potential risk factors in general and specifically in your children with Jacobsen syndrome. And then I'm going to review for you the cases that have come to my attention at least. Then we're going to talk about some of the ways to identify potentially those of your children that might be at increased risk and how to manage these problems clinically, okay? And again, if anybody has any questions at any time, stop. So just to review, I learned of my first case of a brain hemorrhage in a child at our first conference in San Diego, which was actually in 1998. I really was not able to get any more information from the family about what happened. She had a stroke, she was paralyzed, and had to use a wheelchair, and she died a few years ago in her 30s, actually from complications from her congenital heart defect. So that was in 1998, and I never heard about another case of a child with Jacobsen syndrome having a brain hemorrhage until 2010. And in that case, it was a teenage girl in Colorado who suffered a very severe brain hemorrhage, which I'll talk about in a little while. But since 2010, I've learned of 5 more cases. So from 1998 to 2010, none, and then in the last 6 or 7 years, 6 new cases. So that obviously was very concerning, and I wanted to then learn as much as we can to see if we can prevent that in the future. So in terms of, in general, risk factors, there can be genetic predispositions to making a blood vessel in the brain weaker that can then rupture. For Jacobsen syndrome, we know clearly that if you have the bleeding disorder Paris-Trousseau, that can put you in increased risk. There are also clearly certain medications that can put you at increased risk because they can either affect platelet function or the other clotting factors that are involved. We know if you have high blood pressure, that puts more stress on the blood vessels, and that can be a risk factor. There are actually other medications like oral contraceptive pills that can make your blood actually more prone to forming blood clots, which can then go to your brain and cause a stroke. Obviously, if you suffer a bad head injury, that can cause bleeding. And then there can be possibly immune causes. and or infections that can cause inflammation of the blood vessels that make them weaker and more prone to rupture. So in Jacobsen syndrome, there have been a couple of papers that suggest that there might be a gene in chromosome 11 or genes that predispose to this weakening of blood vessels. This first paper in 2001 suggested there might be a predisposition to weakening of the aorta, so that's not in the brain. But then more recently, in 2006, there was a paper that suggested specifically that there could be a genetic predisposition for forming aneurysms in the brain, meaning there might be a gene in chromosome 11 that predisposes to brain aneurysms. I think by now you know very well about the Paris-Trousseau bleeding disorder, and I hope maybe we can get Dr. Favier from Paris to come to this conference because he is clearly the world's expert on Paris-Trousseau. And again, like I said, there are specific medications that can affect the platelet function, commonly used medications like ibuprofen and aspirin. And then there are other medications that aren't used as commonly except for very specific situations, but can also cause problems with the clotting system, namely Coumadin. Maybe some of your children have been on that if they have heart problems, and Lovenox. Those two drugs affect not platelets, but the other part of the clotting system, the specific clotting factors that work together. So high blood pressure can be a cause. Most forms of high blood pressure are what we call idiopathic, meaning we don't really know the cause, but it's common. You see it in families, multiple affected family members. It can also be due to a specific heart defect called coarctation of the aorta, where there's a narrowing in the aorta. Think of it as like a kink in a garden hose, so the pressure above that level of narrowing is very high. And clearly we know that patients that have coarctation, once in a while they actually can present, if not diagnosed previously, with a brain hemorrhage. We just actually had one in San Diego, believe it or not. And then finally, another well-known cause of high blood pressure, which can be very relevant to your children, is due to problems with the kidney. And right now we know that about maybe 10% of all children with Jacobsen syndrome can have structural problems with the kidneys. We think we've found at least one gene, that same ETS1 gene, that might be the cause of that. And if you have a structural kidney problem, that can cause high blood pressure as well. Other medications, like I mentioned before, can be a risk factor. Oral contraceptives, depending upon the dose and which ones, can cause increased clotting. And again, if clots form in the left side of your heart, that can go to the brain and cause a stroke. It's possible when your child has open heart surgery, when they go on the heart-lung machine, that could predispose to clotting and strokes. And sometimes some other type of severe illness can lead to this inappropriate clotting pathway or activation of the clotting pathway. And there are other genetic causes that predispose to increased clotting. Like I said, head trauma, that's pretty self-explanatory. And other problems in terms of infections and or immune problems. If you have like a bacterial infection, that can cause infection of the blood vessels and risk hemorrhage. And there can be even autoimmune or some combination of some environmental trigger that turns on your immune system to attack yourself. That's what's called an autoimmune disorder. That can also lead to weakening of the blood vessels. All right, so now what I want to do is review for you the cases that I've learned about, and then we'll go over the clinical recommendations based on that. So the first case, again, was that young lady that I learned about back in 1998 who had a hemorrhage in her brain, but I unfortunately have not been able to get any more information from that family. And then, like I said, 12 years passed until I learned of another case. In this case, it was a 15-year-old girl in Colorado. They did not identify an aneurysm. The stroke just kind of happened out of nowhere. She was totally fine until she had the stroke. But what was found after she presented with the stroke was that she had very high blood pressure. She did miraculously survive. She has some residual paralysis of her leg, but she's really made almost a full recovery, but she continues to have high blood pressure for which she's being treated with medicines. The third case was probably a case, unfortunately, that some of you know about, a child here in Spain who presented with a very severe headache and passed out. She was actually found to have an aneurysm in her brain. She had surgery. There was extensive damage that left her in a coma, and some days later, she had a second stroke and passed away. The fourth case that I learned about, unfortunately, had a similarly tragic outcome. It was a 24-year-old lady in France. She had been suffering from headaches and then had a spontaneous massive hemorrhage in her brain. Once again, no aneurysm was detected. She did have initially some improvement, but still had a lot of problems, and then unfortunately, tragically suffered a second hemorrhage in the brain. And nothing more specific was identified as the cause. She had been on oral contraceptive pills, and maybe or maybe not relevant, she was known or found to have very low iron levels in her blood. The fifth case happened about 4 years ago. A young man who had pneumonia and inflammation around the heart. Because of that, the heart didn't function well, and so that predisposed to forming clots, which went to his brain to cause a stroke. Was found to have impaired clotting factors, actually, that predisposed to forming blood clots, plus the problem with the heart. She took oral contraceptive pills for about 2 years. She's been able to make a partial recovery, but she's still pretty significantly affected from that stroke. And lastly, a young man from Holland who again seemed to be well and then had a very acute onset of symptoms due to a massive brain hemorrhage for which he underwent surgery to relieve the pressure in the brain. They didn't identify, or they didn't do a study to know whether or not there was actually an aneurysm by MRI, but they did do a CT angiogram, and they did not find any kind of a structural abnormality, and he's made a partial recovery. So in this case, it wasn't very clear, except for the fact that he has Jacobsen syndrome. Here's the second one, so you're right on. Now remember, the female to male ratio of all people with Jacobsen syndrome is about 2 to 1. So the last case is a little bit unusual. This was of an infant with very severe congenital heart disease called hypoplastic left heart syndrome. He had had his first surgery called the Norwood surgery, and because of that, commonly we treat these children with blood thinners when they're in the hospital to make sure they don't form blood clots. So he is being treated with a blood thinner called Lovenox. So remember, Lovenox affects the clotting factors, but this child already has the problem with platelets. So probably the combination was a lethal combination. He subsequently had a massive brain hemorrhage and was severely devastated neurologically by that, and so the family withdrew support. Okay, so just to summarize those cases, I think it's very clear that there's not just one cause, there are multiple causes, so it's multifactorial. In 4 of the 6 cases that we learned something about, there was probably an identifiable cause or causes. Interestingly, with the exception of the last case, most of the cases occurred in older children for whatever reason. And as Sixto just mentioned, it was 5 females and 2 males. So it occurs in both sexes. 6 of the 7, again, occurred after infancy. 5 or 12 or over, 3 in their 20s. And this just lists, again, what I think are the potential, if not absolute, causes. In one case, a brain aneurysm. 2 out of the 4 females had been taking oral contraceptive pills. That may be coincidental or it may be causal. At least in one case, the female from Germany had another genetic factor or a genetic cause to cause an increased predisposition for forming clots. At least in one case, it was due, at least in part, to medical therapy, the Lovenox, the blood thinner. And at least for 3 of the patients, there were probably multiple factors that contributed. So one question is, why did I go 12 years without learning about a case, and now in the last 6 years or so, we've learned about 6 more cases? I don't really think that the actual frequency is increasing. It's probably just because with the internet and social media and whatnot, we're just becoming more aware of these cases. So I want to tell you, in the end of my talk, about how hopefully we can intervene to prevent these kinds of catastrophic events. Keep in mind, I've only told you about 7 cases out of hundreds or probably thousands of people around the world known to have Jacobsen syndrome. So it's a very small number, but if that's your child, obviously that's something very catastrophic. So keeping that in mind, I want to tell you about the different potential imaging modalities that we can use to identify that aneurysm in the brain for those that may be carrying that, and what can we do to prevent that. So that big arrow there shows you a so-called aneurysm in one of the blood vessels here in the brain. So this study is an angiogram. It's an invasive study in which a catheter is placed into the blood vessel that supplies the brain. So it's fairly safe, but it is invasive, and there are risks, but by injecting that contrast material and shooting this special kind of X-ray, it's probably the best study, best method or technology to use, but it is invasive and therefore carries some risks. This next study is a CT angiogram. So this is not nearly as invasive. You do need an IV peripherally, and they inject some contrast, and then you take a special X-ray to give you this kind of an image showing the same aneurysm. The negative about a CT angiogram is that it is a fair amount of radiation, although we're getting much better at limiting the doses. But this is not the kind of study you want to have every day. X-rays we do every day on a lot of our patients in the hospital. You want to really limit this. So in talking to the people in my hospital, this is actually the study that they recommend. It's called an MR angiogram, or MRA. So this is a form of magnetic resonance, so there's no radiation. It does require injecting through a peripheral IV contrast material, but I think you can appreciate there's very good resolution. And so this is the study that my radiology colleagues in San Diego are recommending as a very powerful screening tool. It only takes literally a few minutes, and it's very safe. So just to summarize the clinical recommendations that I have kind of come up with, I think even though it's relatively rare, again, if it's your child, I think most of you would want to know, because there could be ways to intervene to preventing something catastrophic from happening. So the MRA is, I think, a very powerful tool for a screening imaging study. Then you have to ask yourself, what do you do if you find something? Well, that's when it's time to consult your neurosurgeon. Not every aneurysm ruptures. Probably many of us are walking around with at least a small aneurysm that may be of no consequence. But if you find one, like in those pictures, at the very least, you should follow over time. Because if it is expanding, I think that's very likely to require some kind of intervention, which can be done to avoid something catastrophic. I think, as you can imagine, as most of you already know, the medications that can exacerbate bleeding should be avoided. So medicines like aspirin and ibuprofen should really not be used if at all possible. And again, like I mentioned for that last case, the combination of having platelets that don't function normally and then another drug that affects the clotting factors, I think, can be a lethal combination. So we have to be extremely careful in that setting to use the combination. And medicines like oral contraceptives obviously have a role to minimize bleeding, and it's very dose dependent, but we do have to be very careful to not put someone at risk for forming clots that could then go on to form a stroke. Common precautions to avoid head trauma, I think, are pretty self-explanatory. I don't know what the laws are for Spain, but in the United States, any child who rides a bicycle, for example, has to wear a helmet. Anybody that has high blood pressure needs to have a rigorous evaluation to try to find out first the cause, and it should be treated, absolutely. Infections, that kind of ties in with the talk you just heard. Infections really need to be ideally prevented, and if present, treated aggressively. And in at least 2 of the patients that I described, there was a headache that preceded the event. Now, everybody has headaches, and so you're not going to go to the emergency room every time someone has a headache, but be aware. So if your child is waking up in the middle of the night, for example, saying they have a terrible headache, That's pretty unusual, right? How many of you have had your child wake up in the middle of the night with a headache? Pretty unusual. So for something like that, I think that's a potential emergency, and that means going to your emergency room even in the middle of the night. Okay. And we're still learning. So I think hopefully we're not going to learn about many more cases, but because it is pretty rare, as I think you can appreciate from the 7 cases I presented, each one has been very informative. And finally, again, we can't do any of this without your help. And in particular, I want to thank Jimena, who is very helpful to connect me with the family from Spain, and Nigel Barrett from England, who helped connect me with many of the other European patients. And that's it. One quiz question. What's wrong with this picture? This is my son from a couple years ago. Anybody know what's wrong with this picture? Are you from the United States? You're just darn smart. Right, so in Little League Baseball in the United States, or Major League Baseball, everybody has to wear a helmet. So that was just for posing, not for...
Okay,
right.
So thank you very much, Paul, for a very, well, this time it's been worrying information, not so much encouraging, but just one quick question. We could include this, incorporate in the follow-up protocol, but when would you suggest, what age would be sort of ideal for the MRI? Because, just
right.
because probably you'll need sedation.
Exactly. So when should one ideally get the MRA done? Well, because we haven't seen, at least that I'm not aware of, any cases of a hemorrhage occurring, let's say, in a newborn infant, hopefully the risk is very low. And as you just mentioned, if you want to do this in an infant, then you have to give them general anesthesia, which can be a little more complicated. Still, it's safe, but it is another procedure. If your child is having something else done and at the same time is going to need general anesthesia, then I would say see if you can coordinate to get an MRA done at the same time they're having their tonsils out or something like that. Otherwise, I think it's probably okay to wait till they're a little bit older, maybe school age, to get the MRA done when they don't need anesthesia. I think, so what I mean by that is in our institution, I think by the time they're maybe 6 or 7, they can go into the scanner, we play movies for them and music, and they get headphones, and they can be distracted and get the study done without needing anesthesia. So I think in the United States, when we say school age, we mean about age 5 or 6.
Sí, ¿alguna otra pregunta?
No otras preguntas? Okay, great, thank you.
Well, thank you very much, Paul, and all the speakers, por las sesiones de esta mañana.